Good morning, everybody, once again. A warm welcome to UCT-Africa Virtual ENT. I'd like to start by first just mentioning that our thoughts and our prayers are with the people of Beirut and Lebanon during this time. We've had ENT surgeons join us from Beirut previously, and we really hope and pray that you and your families are keeping safe during this time. Just some house rules before we kick in right into our session. I'd encourage everyone joining us to kindly please register using the chat function with your name, email address, institution, and country. I'd further like to remind everyone just to keep their microphones muted throughout the duration of the presentation. And lastly, if you have any questions, you have two options. The first is to type it up on the chat function, or if you prefer to verbalize it, you can raise your hand and I will unmute your microphone and you can go ahead. This morning's presentation is a very, very important one. Dr. Charles Moyo, who's a registrar at the University of Cape Town, will be presenting on HIV manifestations in ENT practice, and certainly in places that are endemic or have a high burden of HIV, this is a very, very relevant topic. So thank you, Dr. Charles Moyo, for preparing this talk. And please, I'll hand over to you. You can share your screen.
Thank you, Tasia. Can you hear me loud and clear?
Yes, I can hear you clearly.
I can't share my screen.
Try it again, Charles.
It's an injection.
Okay. I think I'm on now. Good morning. Good morning, everyone. Welcome again to our Wednesday ENT presentations. My name is Dr. Charles Moyo. I'm one of the registrars here at the University of Cape Town. So today I will lead this discussion on the HIV manifestations in ENT. I should admit this is a very broad topic. As you know, you can't talk about HIV without talking about the opportunistic infections associated with HIV and as well as the side effects associated with the treatment of HIV and treatment of the opportunistic infections. So in preparation of this presentation, there was no intention of any copyright infringement. My content is referenced and there is nothing to disclose. So in terms of the outline of my presentation, I will talk briefly about the history of HIV, epidemiology, the pathogenesis. We'll talk about the natural history of HIV infections, because this will give us a background in terms of when to expect some of the ENT manifestations. And then I will give a summary of some of the most important ENT conditions which are related to HIV. So if we look at HIV, it has had a profound impact on global health since its discovery. So it is believed that it originated in Kinshasa in the Democratic Republic of Congo, and it is thought that it may have crossed from chimpanzees to humans at around about 1920. And if we look again at the history at around 1981 was one of the most important years in terms of the history of HIV. There was a discovery of pneumocystic cardiac pneumonia in about 4 homosexual men in 1981. And later on, they also discovered that some intravenous drug users suffered from this disease entity. So at around 1982, the Center for Disease Control, they used the term acquired immune deficiency syndrome for the first time. And at around 1983 in France, in the Pasteur Institute, this virus was discovered, and initially it was termed the lymphadenopathy associated virus, and it was later coined or termed as the human immunodeficiency virus. That was in May 1986. In one of the most recent developments is that in 2017, for the first time, at least more than half of the people with HIV, living with HIV, were on ARVs. So if you look again at the epidemiology of HIV, about these statistics as of 2019, about 37.9 million people were living with HIV globally, and about 21% of the people didn't know their HIV status. And as we come back to South Africa has got quite a huge burden of HIV, and about 7.7 million in South Africa living with HIV, which gives us to a value of about 20% of the world's population are living with HIV in South Africa. And of the 7.7 million, about 20.4, that is about 1 in 5 of almost every adult are living with HIV. And as of these statistics in 2019, there were about 240,000 new infections. This was in the year of 2018, and about 71,000 AIDS-related deaths, and of which 62% of adults are on ARVs, and about 63% of children are on ARVs. If we look at the basic structure of the HIV virus, it is an RNA retrovirus of the lentivirus genus. That these are groups of viruses which basically affect the immune system. We've got two strains, HIV-1 and HIV-2, of which HIV-1 is the one which is responsible for the global epidemic, and HIV-2 is commoner in the West African countries. So if you look at the basic structure, the virus is covered by the lipid bilayer membrane. So this membrane is derived from the host cell membrane, and it has got these proteins, the GP120 proteins, which are important for the viral attachment to the CD4 count. It has got a GP41 envelope protein. There are also some other core viral proteins like P24 and P17. These are also important in terms of identification of the virus. And in terms of its genome, there are regulatory genes like the touch and the nerve and the web genes. However, their discussion is probably beyond the scope of our presentation for today. If we look at the pathogenesis of HIV infection, initially we have got the virus, and the virus attaches to the host cell CD4 count containing cells with the GP120 protein, and after that there is a fusion of this cell membrane with the viral cell membrane, and the viral based transcriptase then synthesizes viral DNA, and then this viral DNA is then incorporated into the host cell's DNA to form a provirus by the virus enzyme integrase, and then this provirus will then drive this, the host cell's genetic material to form more viral proteins, and more viral proteins are built, and this is how you get a fulminant viremia at the end. And then, if you look at the natural history of HIV, we look at it in three ways. Initially, we have the seroconversion stage. You have this asymptomatic stage, and then you have the stage whereby you get a full-blown HIV. So in the initial seroconversion phase, about 50% of the patients will get symptoms like fever, generalized malaise, generalized lymphadenopathy, and this stage is characterized by a rapid decline in CD4 count and rapid. In terms of the natural history of HIV infection, we basically have got three stages. The first stage is the seroconversion stage, whereby your patient may get, about 50% of the patients get mild symptoms like generalized malaise, fever, generalized lymphadenopathy. This is actually characterized by a rapid rise in your viral load and a rapid decline in your CD4 count. And then the second stage is the asymptomatic stage, whereby there is a bit of a control in terms of the viremia from the body's immune system. And most patients are asymptomatic during this stage. And this stage is characterized by an improvement in terms of the CD4 count and a bit of a decline in terms of the viremia. And the last stage is the full-blown AIDS stage, whereby there is a decline in CD4 count, there is emergence of opportunistic infections, and if there is no treatment, it results in mortality. So in terms of HIV and ENT, there is a well-established link between HIV and ENT, and most literature, or over 80% of patients living with HIV at some point will present with an ENT manifestation of the disease. The commonest manifestation, oropharyngeal manifestation, which account for about 49% of ENT presentations in HIV patients. We also have got neck swellings, things like cervical lymphadenopathy. We've got nasal complaints, so we've got ear complaints. These statistics were according to this a paper which was published in the American Journal of Autologic that was in May 2016. So if we look at their findings in this series, in terms of oral and oropharyngeal manifestations, oral candidiasis was high on the list. In terms of neck manifestations, cervical lymphadenopathy was high as well on the list. Nasal symptoms, sinusitis, things like epistaxis, and also we have got autological manifestations with otitis media being the most common. So there is some local data which was published from Steve Biko Academic Hospital in Pretoria as well in 2013 by Chilufalo. This was a one-year prospective study which involved 153 HIV-infected patients, and typically their patients presented in early stages, clinically WHO stage 1 and 2. And in terms of autological manifestations, they found that a chronic suppurative otitis media was high up on the list. Otitis media with effusion was also high in incidence, and there were things like sensory neuronal hearing loss, vestibular or cochlear involvement, as well as the seventh nerve involvement in otitis externa, one of the more common conditions. Then in terms of rhinological manifestations, adenoid hypertrophy was high on their list, followed by allergy symptoms, sinusitis, and they got things like atrophic rhinitis, epistaxis, nasal polyps, neoplasms, and septal perforations being of note as well. And in terms of the oral cavity manifestations, tonsillar hypertrophy was high on their list, and candidiasis as well. And there were other entities like tonsillitis, stomatitis, as well as ulcers. In terms of head and neck manifestations, the cervical lymphadenopathy was high on the list. It's actually one of the most common findings in terms of ENT manifestations of HIV. And there was also findings of parotid enlargement, Kaposi sarcoma, vocal cord palsy, as well as neck sepsis. So this paper was published by one of our professors here when she was still a senior registrar. You may as well want to look at this. It has got a good summary of generally all the or most of the ENT manifestations in patients with HIV. So I took this summarized table from hematological and autological manifestations, as well as head and neck manifestations. So I will go through each and every sub specialty of ENT and try and discuss some of the most common disease entities which you find in HIV patients. So in terms of oral cavity manifestations, oral candidiasis is quite high on the list. It is one of the most common findings in HIV patients. Particularly you need to take note that in pediatrics, it's quite usually quite extensive, and they may present with feeding difficulties, and which may warrant admission and treatment with IV medication. So it may be associated with esophageal and oropharyngeal candidiasis. There are 4 different types. Basically, we have got the pseudomembranous type, which is the classic form of oral candidiasis, which I think we are used to. It presents as a white plaque that can be scraped off, leaving an erythematous bleeding base. This is basically how a pseudomembranous candidiasis looks like. And then you can have the hyperplastic form, which usually may be confused with oral hairy-leukoplakia, because this one cannot be scraped off, and it presents as thick white plaques, and it can be on the lateral surface of the tongue, causing a diagnostic dilemma with the oral hairy-leukoplakia. So if you are always in doubt, you always need to take a biopsy. And then the other form is an atrophic form, or you may call it an erythematous form, which presents as a flat atrophic lesions, usually on the dorsal aspect of the tongue, and it usually affects the subsequent opposing surfaces. So if you find lesions on the dorsal of the tongue or on the hard palate, you always need to examine the opposing surface for associated lesions as well. And it may as well present as a cheilitis with oral commissure lesions, which are involving the adjacent skin. So in terms of treatment, if it's mild or moderate disease, it's oral candidiasis is amenable to topical therapy with nystatin, clotrimazole, or amphotericin local therapy. But if it's esophageal candidiasis or extensive oral candidiasis or oropharyngeal candidiasis, you may need to treat this patient with systemic therapy. Or if they fail to respond to topical agents, or they are worsening immunocompromise, so the treatment of choice is usually fluconazole. However, if your patient needs intravenous agents, there is room for amphotericin or echinocandin, which are usually as well indicated for certain cases. And then we go into oral hairy-leukoplakia. This entity is a pathognomonic for HIV infection, and it is typically on the lateral border of your tongue, and you cannot scrape it off like a pseudomembranous candidiasis. So they present as white, raised, corrugated, or filiform lesions, and they are usually asymptomatic and require no treatment. And then you get as well recurrent aphthous ulcers. They are in HIV patients. These ulcers are relatively larger and they are painful. They can either be solitary or multiple lesions, and they are well erythematous halo. So treatment is basically aimed at symptomatic relief with either topical steroids, topical anesthetic agents, with or without antibiotics if there is associated bacterial infection. However, in most of HIV patients, these ulcers, they tend to recur and they tend to be resistant to treatment at times. And there are some papers which have suggested thalidomide as one of the treatment modalities, but you should take note that you should exercise caution if you are to give thalidomide to pregnant women, because it is teratogenic. So in one article I looked they looked at the efficacy and safety of thalidomide on the recurrence interval of continuous recurrent mouth ulcers. So this was their primary outcome, and it was a randomized controlled trial in the 60 patients, and about 32 were on thalidomide 100 milligrams daily for 10 days and tapered down to 50 milligrams daily for 10 days, and about 28 patients were on prednisone on 0.4 milligrams per kilogram for 15 days, and which was subsequently tapered down to 0.2 milligrams per kilogram body weight for another 15 days. So in terms of primary outcome, there was improvement in the recurrence interval in the experimental group, and in terms of the secondary outcome, that is the pain, the number, sorry, that was a typo, the number of ulcers and the days for ulcer healing, there was really no change between the experimental group and the control group. So they recommended use of thalidomide in cases of continuous recurrent mouth ulceration. And then we can, these patients, they may as well get oral simplex infection, and usually these lesions are painful and they are larger in HIV patients. They become more numerous and they tend to recur more and persist for longer periods as well. Simplex virus type 1 is the most commonly implicated pathogen, and they present as a Herpes labialis with fever and also blisters around the mouth. So the treatment is oral acyclovir, and they are as well amenable to secondary prophylaxis for cases of persistence or frequent recurrence episodes. And then we look at the dental issues again in HIV patients. Gingivitis is quite common, and they as well present with gum bleeds with very minimal trauma. For example, if they are brushing their teeth, and they can get periodontitis, that is loosening of the periodontal tissues, which may progress to actually destruction of these tissues, which and causing a necrotizing ulcerative gingivitis. And the treatment of choice for these lesions is chlorhexidine mouthwash with antibiotics with anaerobic cover. And it is important to refer these patients early to the dentist. You can also get lesions associated with human papillomavirus, warts on the tongue. These are usually verrucous plate or spike lesions, and are usually associated with anogenital lesions as well. But if finding of an isolated oral cavity, you need to be aware that these can be quite extensive and more likely to recur. However, the treatment of option available for this disease entity is surgical excision. And in the advent of HIV, Kaposi sarcoma is quite common. It's one of the opportunistic tumors involved in HIV. It is actually the most common HIV-related tumor, and it is caused by a co-infection of HIV and HHV, human herpes virus 8. It can either present as cutaneous lesions or mucosal lesions, and these lesions are quite common in the head and neck region, particularly in the hard palate and in the gingiva. So the treatment of choice, first-line treatment of choice is putting these patients on antiretroviral therapy. However, if it fails, chemotherapy is as well a treatment of choice. And for localized disease, surgery, radiotherapy, laser excision or cryotherapy is as well a treatment of choice. And as a differential of Kaposi sarcoma, you have bacillary angiomatosis, which can present in HIV patients as a friable vascular papule. It is caused by a bacterial infection, which results in vascular proliferation. So biopsy is the diagnosis of choice for microbiology in these patients, so that you can differentiate it from Kaposi sarcoma. And the treatment of choice is antibiotics, that is erythromycin. And then as we go to the autologic manifestations, I took this table from one of our open access chapters, which was published by Dr. Harris. So you need to be aware that in terms of autologic manifestations, the mechanisms of pathology in the ear can either be due to the direct effects of HIV as well as the indirect effects of HIV. If we're looking at hearing loss as a manifestation of HIV infection, you may get a sensory neuronal hearing loss, you may get a mixed hearing loss, as well you may get a conductive hearing loss. But if you get a sensory neuronal hearing loss, it can either be due to the direct effects of HIV on the central nervous system, or indirect effects due to the opportunistic infections or autotoxic medication. And it is worth noting that some of the treatment options for your opportunistic infection, for example, multidrug-resistant TB with the use of aminoglycosides, may as well exacerbate the autotoxicity effects of HIV. And ARVs treatment, particularly nucleoside-based transcriptase inhibitors, have been indicated as well as a cause of sensory neuronal hearing loss. So if you look in the external ear, though we know malignant otitis externa is much more common in diabetic patients, it is as well of higher incidence in HIV patients. And in terms of the causative organism, it is similar in the HIV and non-HIV patients. If the HIV, for instance, the HIV-infected patient has got high CD4 count, but as the CD4 count becomes low, for example, less than 50, you get quite invasive infections like aspergillus. So you need to take note of that when you are assessing your patient. So the treatment modality depends on the causative organism. If it's a bacterial infection, you use antibiotics. If it's a fungal infection, you use antifungal medication with or without a surgical debridement if it's indicated. And then you can also get an extrapulmonary pneumocystis presenting, for example, as a cystic lesions or as a external auditory canal polyps, though this is quite rare, but the treatment of choice is the same as the intrapulmonary lesions. We use sulfamethoxazole, the trimethoprim or dapsone. So as we go into the middle ear, the serous and recurrent otitis media are the most common entities. This is due to underlying eustachian tube dysfunction. HIV patients, they can get adenoid hypertrophy with associated lymphoid hyperplasia. They also get sinusitis and allergies. So all these factors, they contribute to your recurrent otitis media and to your otitis media with effusion. So it is important if, for example, if you find a patient with a unilateral otitis media or otitis media with effusion, it is important to exclude a nasopharyngeal neoplasm with a flexible nasal endoscopy and a biopsy in these patients. So in terms of management, we tend to use a conservative approach to these patients. So for symptomatic relief, you want to do a merigotomy with a grommet insertion, but of paramount importance is that you need to manage the underlying condition, which is causing this recurrent otitis media or serous effusion. And adenoidectomy is indicated if there is failed conservative measures. So in our center, these patients, if they present with OMEs with adenoid hypertrophy, we do a post-nasal space biopsy. If we exclude TB and malignancy, if we exclude TB and malignancy, we treat them medically, and we do adenoidectomy if there is a complete obstruction or if they've got obstructive sleep apnea syndrome or signs of obstruction from adenoid hypertrophy. Otherwise, they are amenable to to medical therapy, starting with your ARVs, of course, if the patient is not on ART. So I also looked at this paper which looked at the prevalence of antibiotic-resistant otitis media-associated bacterial flora of asymptomatic patients living with HIV. This was a Tanzanian study. So they recruited about 290 patients with CD4 counts ranging from 0 to normal values, and they found that the prevalence of otitis media-associated bacteria was about 93%, and of those, the most common organisms they isolated were Staph aureus, Klebsiella, as well as E. coli. And in terms of resistance, the majority of the bacteria they found were resistant to most of the usual medications that we use, and most of the bacteria which were resistant were the streptococcal species, that is the Streptococcal pneumonia and the Streptococcal pyogenes. So it is worth noting that at times these patients who present with the otitis media, they may be resistant to treatment. So in those instances, we also need to take note that if there is failed medical therapy, you need to also exclude TB in those cases. So again, TB is the TB mastoiditis or TB of the middle ear. It is a quite a common entity, but she's worth noting that in HIV patients, it doesn't present with the classic signs like multiple tympanic membrane perforations, painless arterial granulation, or bone necrosis. However, you should tailor your clinical findings to your history as well as your examination findings. So if a patient is presenting with a positive ER-positive TB contact, they've got chest symptoms, they've got constitutional symptoms, they've got ear manifestations as well. So you can do simple tests like a chest X-ray and the sputum for gene spec and for acid fast bacilli to confirm the diagnosis. So the treatment is anti-TBs for a minimum of 6 months. And if we look at the inner ear, I got some of the information in terms of HIV and inner ear disease from this article, which was published in 2012 by Dr. Harris, one of our consultants here. So in this review, they actually found that about 21 to 49% of HIV-infected patients develop high-frequency sensory neuronal hearing loss. And the pathogenesis of hearing loss, as I alluded previously, it's multifactorial. You can get direct CNS involvement by HIV. You may get opportunistic infections. Examples are CMV infection, HSV infections, varicella zoster virus, syphilis, as well as cryptococcus infection. You may as well get neoplasms like non-Hodgkin lymphoma as well. And in terms of drugs, nucleoside reverse transcriptase inhibitors have been indicated as well as isoniazid, microlith, and aminoglycosides. It is worth noting that it has been shown that HIV patients are more susceptible to aminoglycoside toxicity due to the direct effects of HIV on the cochlea, and as well as ARVs, particularly nucleoside reverse transcriptase inhibitors, which cause defects in your mitochondrial genetic material. So even though rare autosyphilis can present in HIV patients, and the typical presentation is hearing loss, which is sparing the mid-frequency ranges with associated tinnitus and vertigo, which mimics Meniere's disease. So the diagnosis is serology. We want to do your VDRL and your RPR to confirm the diagnosis. And in terms of your CT scan, radiological CT scan findings, you may find these gammas in the internal auditory canal, or you can get osteitis or osteolysis in the temporal bone. And the treatment of choice for otocyclosis would be your high dose propane penicillin with probenecid, and the use of steroids is controversial. Some advocate for the use of steroids if there is no contraindication. You may as well get facial nerve involvement, which occurs in up to about 7.2% of HIV patients. So the etiology is either by direct HIV infection or direct HIV effects on the cervical cranial nerve, or you can get neoplasms, opportunistic infections like toxoplasmosis, or you can get AIDS encephalopathy presenting as your seventh cranial nerve fallout. So Bell's palsy is the most frequent diagnosis, and it is postulated to be caused by simplex virus. However, there is usually complete recovery for these patients within 3 weeks to 6 months. And in terms of facial nerve involvement, you may get Ramsay-Hunt syndrome. It is actually more prevalent again in HIV, and it presents as severe hepatic pain in the dermatomes in the distribution of the facial nerve. And you may get vesicles in the concha bowel. As you know, the facial nerve also supplies secretion to the concha bowel. So the treatment of choice for the Ramsay-Hunt syndrome would be a high dose of cyclopam without steroids if there is no contraindication. So you should note that if you find a bilateral facial nerve palsy, it is actually more likely to be associated with a systemic disease entity. And then we move on to the nose and the paranasal sinuses. So about 30 to 60% of patients who present with their nose and paranasal sinuses symptoms. So with nasal obstruction being the most common complaint, and as well as allergic rhinitis and sinusitis being more common. We've already talked about adenoid hypertrophy as well, and the finding of adenoid hypertrophy in adults warrants one biopsy to exclude malignancy and to exclude TB, and also need to refer those patients for HIV testing. So it is the adenoid hypertrophy is mostly due to lymphoid hyperplasia, which is secondary to B-cell activation by other HIV or other associated infections like CMV and Epstein-Barr virus. So the treatment is mostly conservative. You want to give a medical treatment and then a surgical management if there is failed medical treatment. So sinusitis, the etiology of sinusitis, bacterial sinusitis is similar in HIV and non-HIV patients. However, you should note that as your CD4 count gets below 200, you get bacteria like Staph aureus and Pseudomonas bugs being more prevalent. And as the CD4 counts declines more with CD4 counts of less than 50, your fungal infections like your mucormycosis and as well as invasive Aspergillus fungal species become more common as well. So, and then the management is same. You want to treat these patients medically and then surgically if there are complications or if there is no response to medical therapy. So you may as well get neoplasms in the nose, like sarcoma in the nasal cavity, and non-Hodgkin's lymphoma as well. And you may get midline lesions like your T-cell lymphomas as well, presenting in these HIV patients. So if we look at the pharynx, the larynx and the esophagus, we've spoken about candidiasis, which is more common in the oral cavity, but you may get oropharyngeal candidiasis, esophageal candidiasis, which present with severe dysphagia and with worsening of the cachexia associated with HIV. And you may get a barium swallow for these patients, and you will see an irregular cough stone. And you may need to do a panoscopy for this patient to exclude Kaposi sarcoma or other you may get CMV-related ulcers, which are usually found in a third of patients. They are commonly in the distal esophagus. And this is a differential diagnosis in patients with suspected esophageal candidiasis who have failed on antifungal therapy. And to confirm the diagnosis, you need a biopsy and culture of the virus. And the treatment of choice is IV ganciclovir and foscarnet. So you may get your herpes simplex infection as well in the pharynx, the larynx. Particularly in the pediatric population, they may present with acute signs of air obstruction, stridor, respiratory distress, and not being able to feed. And you may want to treat these patients, admit these patients, and treat them with IV acyclovir because they tend to get extensive disease in the pediatric population. However, herpes simplex infection is quite common when the CD4 count declines to less than 100 per ml. And you may also get idiopathic esophageal ulcers, which are similar to the CMV ulcers in terms of appearance. And these ones are treated with systemic steroids. And some advocate thalidomide juice as well for this idiopathic ulcer. And go on to neck manifestations. So the neck manifestations, they are present in up to 90% of patients with ENT manifestations. As I alluded to previously, cervical lymphadenopathy is actually the most common finding in terms of head and neck manifestations. So your differential diagnosis will include HIV lymphadenopathy, your carotid disease, your infections, as well as your neoplasms. So in up to 70% of cases, the HIV patients present with a persistent generalized lymphadenopathy, and the cervical region being the most common. These lymph nodes are usually small, mobile, they are non-tender. However, you should take note of the following entities which are indications for biopsy. If you've got a rapidly enlarging lymph node, if you've got a prominent lymph node, asymmetrical lymphadenopathy, if you've got a firm non-mobile node, there is associated constitutional symptoms, you need to biopsy those lymph nodes so that you can exclude the malignancy or TB. And then if you look at the salivary glands, both your minor and major salivary glands are not immune to HIV infection. So the most common complaint is xerostomia, and we will look at as well lymphoepitheliasis, which are common in the parotid region. They are now termed benign lymphoepitheliasis. These cysts are pathognomonic of HIV infection. They are usually progressive and multiple, painless bilateral parotid cysts, and the diagnosis is by finding aspiration and imaging. And the treatment of choice, the initial treatment of choice, we want to put this patient on ARVs if they are not on ARVs. There are treatment modalities like sclerotherapy, and surgery is indicated for cosmesis reasons, or if you want to confirm the diagnosis, or if you are suspecting other underlying conditions, or if there is recurrent infections, these disease entities are amenable to surgery as well. So in our center, we still do alcohol sclerotherapy for these patients. If you look at this paper, which was published in 2009 by Dr. Mayer, one of our consultants here. So they looked at about 11 patients, and they wanted to determine the effectiveness of alcohol sclerotherapy in patients with HIV-related salivary gland disease. So in our clinic, we basically use 95% alcohol. We use a butterfly needle, and then initially we aspirate the cyst contents, and then you want to inject at least 25% of the amount of your alcohol amount should be about 25% of the amount which you aspirate it. So you inject the 95% alcohol, and then we leave it for about 10 minutes, and then we re-aspirate. This is done under local anesthesia. If you don't do it under local anesthesia, patients usually complain of pain. So in terms of the results, this study showed that alcohol injection sclerotherapy proved to be an effective, simple, and cheap ambulatory procedure for patients who did not qualify for antiretroviral treatment, for patients who cannot access antiretroviral treatment. This is another treatment of choice. So in terms of conclusion, globally, Africa has the highest prevalence of HIV, particularly in South Africa, and otolaryngologists should have a low threshold to conduct HIV testing in patients with common HIV-related conditions. And once you have HIV confirmed in the patient, there is always a need to exclude a TB, because these two disease entities, they usually go hand in hand. And a multidisciplinary approach is key in managing most of the HIV-relatedness. Most of the time, is an isolated ENT disease entity. They have HIV treatment and suppression of the viral load is paramount in the overall management of HIV. References. Thank you. I will open up for any comments and discussion.
Great. Thank you very, very much, Charles, for the highly informative talk. I'd like to open up the floor, perhaps to start with our faculty at the University of Cape Town, Dr. Esti Meyer, Dr. Xavier Pierre, Professor Johan Fagan. There are a number of publications that Charles mentioned that you authored. Any comments perhaps on those articles and the presentation in general?
The Charles question, could I ask a question just about HIV? Do they have control groups of patients who are HIV negative? For instance, in papers that list the percentage of patients that have chronic suppurative hepatitis media or tonsillar hypertrophy, unless you have a control group, you don't know how many of those cases are actually caused by HIV, and I'd just like your feedback on that.
Yes, thank you, Prof. Most of the papers in literature with regards to the statistics of HIV manifestation in ENT, they are, most of the papers I came across, they were case series. I can't remember if I came across a paper where there was a control group. Most of them were case series or clinic cases which were reviewed over a certain period of time. I can't remember if I came across any control.
Good. Follow up that, Marcus, overstating the association and how we interpret those kinds of patients, so those kinds of reports.
And sorry, Professor Fagan, we just lost you for the last few seconds there.
Yeah, what I'm saying is that if you don't have a control group, then we might be overstating the association between various ENT pathologies and HIV. Perhaps Tasneem Harris could comment on that as well.
Absolutely, Professor. Absolutely agreed. I'm not sure if Dashneem Harris, Dr. Harris made it for the meeting, but I do see that Dr. Esti Mayer's hand is raised. Dr. Mayer, would you perhaps like to comment?
Good morning to see. Can you hear me?
Yes, loud and clear.
Two issues. So I did a study. We looked at the chronic leaking ears, but that was way back, I think about 2006. And we looked at the pathogens, and we didn't see a difference between the HIV positive and the HIV negative patients. But what we couldn't do is we couldn't test the resistance of eardrops. So we could only test the resistance to oral medication, because it's a whole different ball game to actually look at eardrops. And often the eardrops, like the ofloxacin we use, got a higher concentrate. So I don't think we can just say that those leaking ears often and often they still respond because it's a higher. Careful and just make sure how many patients were actually tested, because when we did the study, there wasn't a difference between the HIV positive and the HIV negative patients, and then we still got the normal pathogens, the Proteus mirabilis, that you would expect in chronic leaking ears. So I think that's the one thing. And always with the otitis media, you must just see, is it leaking ears? Were there maybe cholesteatomas that weren't picked up? So one's got to be very specific on that. The thing with the parotid cysts, we actually don't see that many in our clinic, fortunately, anymore, because when we did that study, it was for the patients that had that couldn't get the ARVs, because then in South Africa, you had to have a CD4 count of less than 200. But the Western Cape's HIV program is so amazing. We now basically, if you are HIV positive, you get treated. So the good thing is we don't see those cosmetically bad cysts anymore. So when we did the study, it was basically because those patients, the CD4 was too high to qualify for ARVs. But now in the Western Cape, definitely they can get ARVs on diagnosis. So we don't see that. We still sometimes do it if the cyst doesn't go away. But luckily, our impression is that the patients don't develop those cysts anymore because they go on treatment. And the screening program, definitely in the Western Cape, hopefully in South Africa, is so good that those HIV patients get very good treatment.
Great. Thank you very much, Dr. Mayer, for those comments. I think very, very important just to highlight, as you said, to optimize your HIV treatment in form of ARVs as soon as possible. Perhaps we'll have time for one question. I see there's a question on the chat function, and I'll open this up to Dr. Moyo and Professor Fagan. Dr. Satya Chaudhry is just commenting and perhaps is asking for some comments from your side on the incidence of oral malignancies in HIV patients. Charles or Professor Fagan, please go ahead.
But we can also ask Professor Hiller to comment on that. He's an oral pathologist. Joost, do you want to comment?
Good morning, everybody. Can you hear me?
Good morning, Prof. Hill. We can hear you.
Good morning to everybody. So the incidence of malignancies in the oral cavity in the HIV setting has actually really not changed if you talk about the incidence in HIV positive patients. So by far the most common pseudomalignancy is Kaposi sarcoma. Kaposi sarcoma is the most frequently diagnosed tumor in Africa. So it goes for oral Kaposi sarcoma as well. And then very close on the heels of Kaposi sarcoma is lymphoma, diffuse large B-cell lymphoma, or plasmablastic lymphoma, which is quite particular to the oral cavity in HIV positive patients. And the other malignancies that we see are probably not directly caused by HIV, such as squamous cell carcinoma. There is no relationship in the prevalence of oral squamous cell carcinoma in countries that got a high HIV rates. So we verified that for South Africa, and it doesn't seem that squamous cell carcinoma is particularly more affecting HIV than other members of the population. So these are basically your malignancies that you'll see associated with HIV.
Great. Thank you very much, Prof. Hill, for your comments. I hope, Dr. Chaudhry, that answered your question. In view of time, I can't accommodate any more questions now, but a great thank you for everyone who participated in this discussion, and Dr. Moyo as well. Thank you for the highly informative talk. I'd like to end the session here and further invite you to our session this Friday. We have a head and neck case discussions, and we have presenters from South Africa and from Kenya as well. So we have some interesting cases lined up day after tomorrow. So a warm welcome to you on Friday at 8:30 in the morning GMT plus 2 hours. Thank you very much to everyone for joining us, and have a lovely day.